I'm just going to give it a minute or two to let some people trickle in. Alrighty, we're going to go ahead and get started. Thank you guys for joining me today for today's Grand Rounds. My name is Rachel Leong, and I am the Nutrition Support Pharmacy Fellow here at UH. And for today's Grand Rounds, we will be weighing in on gastric bypass-related hyperammonemia. I nor my advisor have nothing to disclose. And before diving in, I know what some of you may be thinking. What does this have to do with parenteral nutrition? Well, here at Emory University Hospital, our team is actually a metabolic and nutrition support team. So we are consulted on a variety of unique metabolic disease states. And so today I'll be shedding some light on what that may look like and how we tailor nutrition towards them. Our objectives for today are to describe the clinical manifestation of gastric bypass-related hyperammonemia, which I'll now refer to as GABA, evaluate various mechanisms that may contribute to its presentation, review available treatment options, and then apply our knowledge towards a patient case. Discussing obesity, to start it off, prevalence in the US is around 41.9% between March of 2017 to 2020. And so I've included the weight categories based on BMI. So with obesity, we would expect a BMI of 30 to 39.9, with severe obesity being greater than 40. Typically, obesity, as we know, is linked to many other diseases. So type 2 diabetes, hypertension, hyperlipidemia, heart disease, and many more, leading to a poor quality of life, disability, or possibly even early death. So we're going to start it off with our first audience participation question. A patient with a BMI of 41 has had difficulty achieving weight loss over the past 5 years. Would this patient qualify for bariatric surgery? So our options are A, Yes. B, no. Yep. So I saw a lot of hands for A. So in terms of our other qualifications for bariatric surgery, the first being a BMI greater than 35, regardless of the presence, absence, or severity of comorbidities, a BMI greater than 30, and they have a history of type 2 diabetes, a BMI of 30 to 34.9, and they do not achieve substantial weight loss or comorbidity improvement using non-surgical methods. Overall, a total incidence in 2020, there was less than 200,000 bariatric surgeries performed, with gastric sleeve being the most common, around 61%. With bariatric surgery, it is most effective and long-lasting treatment for severe obesity. It's shown significant weight loss, success rates of weight loss of up to 60 to 70% of excess body weight, and shows improvement, prevention, or resolution of related diseases. Studies have shown that it may reduce a patient's risk of premature death by around 30 to 50%. So looking at some types of bariatric surgery, starting off with the gastric sleeve, around 80% of the stomach is removed, and the remaining is the size of a banana. So it holds less food and liquid to reduce the amount of calories consumed. In turn, the effect on metabolism that it has is that it decreases hunger, increases fullness, in order to maintain a healthy weight and blood sugar control. The next is the Roux-en-Y gastric bypass. They also create a smaller stomach pouch to hold less food. In turn, the food doesn't come into contact with the first portion of the small bowel, leading to decreased absorption. And then next is gastric banding. So with this one, they put an adjustable gastric band device around the top part of the stomach in order to limit the amount of food a person can eat. This one has the lowest rate of complications, and the band can be adjusted and or removed. It does result in slower and less weight loss compared to the other procedures. So for this presentation, we'll be focusing on the Roux-en-Y gastric bypass. All right, we have another audience participation question. Among the following options, which form of bariatric surgery is most likely to lead to nutritional derangements due to decreased absorption of food? Is it A, gastric sleeve, B, a Roux-en-Y gastric bypass, or C, gastric banding? Yep, so our answer is B, a Roux-en-Y. So in addition, there are many other complications that come with gastric bypass surgery, such as small bowel complications and obstructions, dumping syndrome, which is exactly what it sounds like. It's a result of poor food choices, such as refined sugars or high glycemic carbs that cause rapid gastric emptying. In turn, it leads to symptoms such as diarrhea, nausea, and feeling lightheaded after a meal. The next being nutritional derangements, as well as rare neurological manifestations, which are the two we'll focus on today. So starting off with our nutritional derangements. In 2019, an update in the clinical practice guidelines for peri-op nutrition, metabolic, and non-surgical support for patients undergoing bariatric procedures included this table on micronutrient deficiencies post-bariatric surgery. So looking first at vitamin B1, less than 1 to 49%, depending on the type of bariatric procedure that was done, showed deficiency in these patients. With vitamin B12 at 2 to 5 years post weight loss surgery, with less than 20% in the Roux-en-Y. With folate, up to 65% of patients showed deficiency. With iron in the Roux-en-Y, around 20 to 55% of patients. Vitamin D and calcium, up to 100% of patients showed deficiency. With vitamin A, up to 70%. Vitamin E and K were a little less common. With zinc, up to 40% post Roux-en-Y. And with copper, around 10 to 20% in our patients. So for your reference, I've included this table on the both fat and water-soluble vitamins, including the type of sample drawn, the reference range, as well as some common symptoms of deficiency. So thinking about our eyes, skin, mental status, and anemia with our symptoms. For your reference, I've also included a table on our minerals. So with copper, looking for symptoms of deficiency such as anemia, hypopigmentation. Selenium shows cardiomyopathy and anemia. Zinc with delayed wound healing, weight loss. Manganese, also weight loss, dementia, dermatitis, and iron are common symptoms of fatigue and alopecia. So our next audience participation question: delayed wound healing is most likely associated with which micronutrient as a symptom of deficiency? Is it A, niacin, B, zinc, C, thiamine, or D, copper? Yep, our answer is B, zinc. All right, so why are our micronutrients so important? Our trace elements are cofactors in metabolism. Vitamins are coenzymes in metabolism. They have antioxidant properties and genetic control. So this might look like synthesizing DNA, facilitating growth, producing digestive enzymes, breaking down our carbs, fat, and protein. Things to keep in mind with our micronutrients: typically levels are not routinely measured. Most take a few business days as they are sent out labs, so they take a little bit longer for turnaround time. With timing of blood sample and certain conditions, they can affect our results. Moving on to our neurological manifestations. These typically occur in 5 to 10% of our patients after bariatric surgery. Some common complications include encephalopathy, so Wernicke's encephalopathy, whether it's associated with D-lactic acidosis or hyperammonemic encephalopathy, which is what we're focusing on today. Other complications include behavioral and psychiatric disorders, myelopathy, and optic neuropathy, with the most common underlying mechanism as nutritional deficiencies. So hyperammonemia is a metabolic condition characterized by raised levels of ammonia. It's a nitrogen-containing compound produced in the colon, small intestine, and muscle. It's then transported to the liver, then converted to urea via the urea cycle, then excreted via the kidneys. Some of our causes of hyperammonemia, so it can be split into congenital versus acquired. For congenital, it would be from a urea cycle defect, organic acidemia, congenital lactic acidosis, a fatty acid oxidation defect, or dibasic amino acid deficiencies. With acquired, it can be separated into hepatic versus non-hepatic. So with our hepatic, there's 3 different types. So type A, from acute liver failure, so typically thinking viral hepatitis, ischemic hepatitis, or ingestion of hepatotoxins. Type B, from portosystemic shunts with no underlying cirrhosis or liver disease. And type C is cirrhosis and portal hypertension, which is the majority of our cases, around 90%. With non-hepatic, typically from a hematological disorder such as multiple myeloma or acute leukemia. Infections from urease-producing organisms, drugs such as valproic acid, topiramate, valproate, carbamazepine, salicylates, and sulfadizine, as well as unmasked urea cycle defect. For our diagnosis, we would want to obtain an ammonia level lab draw. We want to make our nurses aware to put it in ice water rather than ice alone, as directly contacting the ice can result in hemolysis and lead to falsely elevated levels. Normal reference range here at EUH for our adults is less than 50. In terms of our physical assessment of hyperammonemia, it's typically non-specific, so an increased respiratory rate and dehydration won't really help us much. So we really focus on that neurological evaluation for a complete assessment. So there are 5 different grades, with grade 0 being minimal hepatic encephalopathy with minimal changes in concentration and memory. Grade 1, some changes in sleep or lack of awareness. Grade 2, lethargy, some changes in personality and slurred speech. Grade 3, they're typically somnolent but can be aroused, have some marked confusion and disorientation of time and space. Grade 4 with a coma, and they may or may not respond to painful stimuli. So typically with our life-threatening complications, we expect to see an ammonia level greater than 200, and they'll typically have symptoms of seizures, encephalopathy, and may lead to death. So all of that brings us to our main topic today, gastric bypass-related hyperammonemia. There are some cases published, around 10 to 15. However, there's just not a lot of data out there. So there's minimal guidance on diagnosis and treatment. In turn, it's an under-recognized but treatable complication as we've seen here. Typically, it can lead to rapid decompensation and poor outcomes, and they've documented a relatively high fatality rate of around 50%, which is why I wanted to do this presentation today. So looking at our clinical presentation for our patients with GABA, typically these are middle-aged females presenting with no history of liver disease. They have a variable post-surgical time course, so it can occur around a month to 28 years. Again, difficult to determine with such a large time frame, so it can really happen at any point. They typically have successful weight loss post-Roux-en-Y. And then looking at our laboratory hallmarks, we'll see an elevated ammonia, elevated plasma glutamate, hypoalbuminemia, our nutritional and essential amino acid deficiencies, as well as a low zinc. So included here are some patient cases that we've come across here at EUH. As you can see, they present very similarly. So they are that middle-aged female. They come in with ongoing abdominal pain, decreased oral intake, weakness causing falls at home. Again, they all presented with that history of gastric bypass, variable timeframes. They've had relatively large amounts of weight loss, ranging from 40 to 200 pounds. And they all present with an elevated ammonia level. So in 2015, there was a case series published on hyperammonemia-induced encephalopathy in relation to bariatric surgery in the World Journal of Hepatology, where they created a diagnostic algorithm for a patient that presents with GABA. So if they present with hyperammonemia and no liver dysfunction, they then checked an arterial pH. If they were acidotic, it may have been due to an organic acidemia or pyruvate metabolism abnormality. If they are alkalotic or had a normal pH, potentially then looking at the glucose level. So if they had hypoketosis and hypoglycemia, potentially being due to a disorder of fatty acid oxidation. If they were normal glycemic, then due to a urea cycle disorder, which is what we'll be focusing on today. So thinking of a potential mechanism and trigger of GABA, again, with our masked urea cycle defects, typically these are inborn errors of metabolism from defects in the enzymes or transporter molecules involved in hepatic removal of ammonia from the bloodstream. However, with gastric bypass, these symptoms can develop during stressful periods. So thinking starvation, malnutrition, post-surgery, even in pregnancy, with the most common denominator being that nutritional deficit. So taking a little closer look at our urea cycle, our first step is our rate-limiting step, which involves the conversion of CO2 and ammonia into carbamoyl phosphate. And ammonia is the source of the first amine group of urea. Our second step, carbamoyl phosphate and ornithine combine to form citrulline via ornithine transcarbamylase, or OTC. Citrulline then reacts with aspartate to form arginosuccinate via arginosuccinate synthetase, and this step requires ATP. Aspartate is the source of the second amine group on urea. For step 4, arginosuccinate is then converted into arginine via arginosuccinase, and this reaction gives off fumarate. In step 5, arginine then undergoes hydrolysis via arginase to form urea and ornithine, and once it's been converted to urea, then it's excreted by the kidneys. So once we suspect a urea cycle disorder, we would then want to take a look at a citrulline level. So typically how we would check this is through an amino acid profile. If the citrulline level is elevated, we would then want to check an arginosuccinic acid level, again on a complete amino acid profile. If it's elevated, it would potentially be due to an arginosuccinic aciduria. If it's absent, then due to citrullinemia. If the citrulline level was low, we would want to then check an orotic acid level. However, this is a bit difficult since it would require a liver biopsy to find the enzyme deficiency. If the orotic acid level was low or normal, then it may be due to a carbamyl phosphate synthetase deficiency in the urea cycle. And if it was high, due to an ornithine transcarbamylase deficiency. And I wanted to point something interesting out with our OTC deficiency. This is an X-linked genetic disorder. However, it can present during catabolic stressors in heterozygous OTC deficient women. In turn, it kind of explains why it typically happens in women. So this is something we definitely check in our amino acid profiles. Also, zinc deficiency has been proposed to interfere with OTC function. And as we saw before, zinc is typically low in our patients post Roux-en-Y. Other potential mechanisms or triggers for GABA, there's a high nitrogen load from rapid weight loss, reduction in nutrition intake resulting in catabolism, leading to protein breakdown in the extrahepatic tissues. There are gut microbiome alterations, which can increase portal systemic recirculation of ammonia. So now we'll move on to our treatment for GABA. So overall, our goal is to reduce ammonia levels while also providing nutritional support in order to reverse catabolism. So first, starting off with our nutrition management. So with oral and enteral nutrition, this is typically not preferred as it's difficult to tailor our nutrition for these patients. So we do prefer parenteral nutrition, typically including just our dextrose and lipid infusions. The reason being we want to be able to limit our amino acid and protein intake. As we saw in our urea cycle disorder, protein breakdown may or may not lead to worsening of hyperammonemia. With this, again, mentioning getting that aminogram to see potentially where in our urea cycle the patient may have a defect. For our micronutrients, drawing those labs early. So our vitamins A, B, C, D, and E, minerals, copper, selenium, zinc, as well as getting a total and free carnitine and supplementing any of those low labs, which we can do inside our parenteral nutrition or outside. All right, moving on to our amino acid supplementation. So this would be in addition to our parenteral nutrition. So levocarnitine is typically depleted in malnourished patients as well as those receiving renal replacement therapy. So dosing for deficiency, depending if they're primary or secondary deficiency, would be 990 milligrams by mouth 2 to 3 times per day. With secondary deficiency, 50 mg per kg per day, IV in divided doses. And then our next being IV arginine. So this is typically used for treatment of acute hyperammonemia if they have a presence of deficiency in those listed below. If they have an unconfirmed or pending diagnosis, we would dose with an IV loading dose of 600 mg per kg with the same dose for the continuous IV infusion. For ASS or ASL deficiency, again, same dosing for loading dose and the continuous IV infusion. For CPS, OTC, or NAGS deficiency, starting off with an IV loading dose of 200 mg per kg, and then same dose for a continuous IV infusion. And then I wanted to point out some dietary supplements that we would not want to use, and those are the ones including glutamine. So something that we carry here at EUH is Juven, and it contains arginine, glutamine, HMB, micronutrients, and some collagen protein. And the reason we want to avoid glutamine is the reason that increased glutamine synthesis occurs in response to increased ammonia levels in the brain. Hyperammonemia exceeds the brain's capacity to synthesize glutamine, which then causes ammonia concentrations to rise significantly. All right, our next audience participation question. What is the reasoning for discontinuing Juven in patients with gastric bypass-related hyperammonemia? Does it A, interfere with zinc production, B, limit lysine intake, C, depletes copper stores, or D, limit glutamine intake? Awesome. Yep, so the answer is D, as we had just discussed previously. All right, our next step in our treatment is our pharmacotherapy management. So first being lactulose, its mechanism of action is through the colonic breakdown of lactulose to lactic acid. It leads to acidification of the gut, and it favors formation of ammonium from ammonia. It traps the ammonium in the colon and reduces plasma ammonia concentrations. Our dosing for lactulose is 20 to 30 grams by mouth every 1 to 2 hours for around 2 soft stools per day. And then to reduce it to 20 to 30 grams twice a day to 4 times a day, adjusting the dose every 1 to 2 days to achieve 2 to 3 stools per day. Our next is rifaximin, which reduces ammonia production by eliminating ammonia-producing colonic bacteria. And we would dose it with 550 milligrams by mouth twice a day. Our next agents are our ammonia scavenging agents. So with sodium phenylacetate, sodium benzoate, the brand name is Ammonul. It's dosed in patients greater than 20 kilos with a loading dose of 55 mils per meter squared, administered over 90 to 120 minutes. The maintenance dose is the same dose over 24 hours. Some clinical pearls with this medication is that it must be administered via a central venous catheter. And typically a repeat loading dose isn't recommended due to neurotoxicity with prolonged plasma levels of phenylacetate. The cost is relatively high. It's around $48,000 for 50 milliliters, so we typically don't use it as often. Our next agent is sodium phenylbutyrate, or Bufenil. This is typically used when we want to transition to an oral agent. We can start this when ammonia levels are less than 100 and the mental status has returned to baseline. For patients greater than 20 kilos, we would dose them 9 to 13 grams per meter squared per day by mouth, and it's divided into 3 to 6 doses a day with a max dose of 20 grams per day. Our cost for this is also a bit steep, $4,800 for 250 grams, and it is non-form. This also leads to some significant GI side effects, so we do recommend to administer it with a PPI. So in 2007, this study was done in the New England Journal of Medicine on the survival after treatment with phenylacetate and benzoate for urea cycle disorders. The purpose is to identify if this combination of IV sodium phenylacetate and benzoate has been shown to lower plasma ammonium levels and improve survival in patients with urea cycle disorders. So looking at our mechanism of Ammonul, this figure illustrates how the components of Ammonul, so phenylacetate and benzoate, provide an alternative pathway for nitrogen disposal in patients without a fully functioning urea cycle. 2 moles of nitrogen are removed per mole of phenylacetate when it's conjugated with glutamine, and 1 mole of nitrogen is removed per mole of benzoate when it's conjugated with glycine. The methods for this study, it was an open-label, uncontrolled, non-randomized study across 118 hospitals in US and Canada. It occurred from August 1980 to March 2005, and they included patients hospitalized due to hyperammonemia from UCD. Exclusion criteria were if they had incomplete demographic data. The primary endpoint of this study was survival of an episode of hyperammonemia, and they also identified primary and secondary causes of death, assessed the relationship to the primary disease, and study drug. I've included the treatment doses below. For the results of this study, a total of 299 patients with urea cycle disorder, and there were 1,181 episodes of hyperammonemia in these patients. 93 of them were neonates, having 94 episodes, and 237 patients greater than 30 days of age had 1,087 episodes. The mean number of episodes per patient were around 33.3, plus or minus 6.3. Overall survival was around 84% in these patients, with the lowest being in our neonates, so around 73%, and our highest being in those greater than 12 years of age, 99%. Looking at the hyperammonemic episodes themselves, there was a 96% overall survival. 49 patients did die in this study from common coexisting conditions such as seizures, infection, and cerebral edema. In conclusion, treatment with IV sodium phenylacetate and sodium benzoate in conjunction with our other therapies may effectively lower plasma ammonium levels and result in survival in the majority of our patients. The next therapy option that I wanted to discuss is acetohydroxamic acid, or lithostat. Its mechanism is that it inhibits bacteriurease enzymes and decreases formation of ammonia in urine by urea-splitting organisms. Dosing in chronic urea-splitting urinary infection as an adjunct to decrease urinary ammonia levels and alkalinity is an initial dose of 12 mg per kg per day in 3 to 4 divided doses, and a maintenance dose of 250 mg 3 to 4 times daily for a total daily dose of 10 to 15 mg per kg per day, with a max daily dose of 1,500 mg per day. It does have some warnings with it, so it can cause bone marrow suppression, hemolytic anemia, hepatotoxicity, and rash. And in 2017, a clinical trial looked to identify if it prevented hydrolysis of urea by inhibiting bacterial urease of gut flora in healthy control adults and adults with urea cycle disorder. Unfortunately, it was terminated due to the high incidence of adverse events. And so this was one of our more recent potential therapy options for our urea cycle disorders. So we aren't left with many other newer options. Next, we will be discussing renal replacement therapy. So with hemodialysis, it does allow for the highest initial rate of reduction in ammonia levels. However, it can worsen cerebral edema. It has a high risk of hyperammonemia rebound since it clears the blood while the cerebral hyperammonemia persists. With continuous renal replacement therapy, or CRT, it does clear the ammonia more slowly, however, leads to greater total ammonia over a longer duration of time. It also helps with improved fluid balance and temperature control. With peritoneal dialysis, it's not typically considered first line. There's only been few select studies involving some neonates, so typically we would reserve this for less severe patients or when hemodialysis is not readily available. So review was done looking at extracorporeal ammonia clearance for hyperammonemia in critically ill patients. The purpose was to investigate ammonia clearance in our hyperammonemic adult and pediatric patients and to identify some potential factors that may affect the clearance. The methods for the study, it included all publication types published through to May 29, 2020. So you name it, included prospective observational studies, case reports, case series, abstracts, and a total of 28 studies met eligibility criteria. Hyperammonemia was typically secondary to an inborn error of metabolism in children and to liver failure in adult patients. With hemodialysis, it showed time to 50% reduction was faster than the others. With CRT, clearance varied from less than 5 to greater than 250 mils per minute per meter squared. And with PD, it showed minimal clearance, around less than 40 mils per minute in all of the studies. In conclusion, the treatment modality, blood flow, and effluent flow rate appear to affect clearance, with HD achieving the highest values. CRT achieved substantial values, especially at a high EFR, and PD achieved minimal values. We'll now move on to our last mode of treatment, our supportive care. So with our critical care, we would want to treat our underlying conditions and infections, provide hemodynamic monitoring and tailored therapy for fluids, vasoactives, and/or steroids, intubation and mechanical ventilation with targeted CO2 goals, establishing IV access, maintaining a circulating volume and urine output, and to monitor blood glucose and electrolyte levels. With our neurocritical care, maintaining appropriate sedation and analgesia goals, targeted temperature management focused on avoiding fever. Sodium targets should also be clearly established, continuous seizure monitoring, and if indicated, anti-epileptic medications, excluding valproate. And if cerebral edema develops, we would want to elevate the head of the bed, escalate our sodium targets with consideration for hypertonic saline and/or mannitol. So we'll now apply our knowledge to our patient case. So bringing it back to that first patient case in our table from earlier, SH is a 41-year-old female who presents with ongoing abdominal pain, nausea, vomiting, decreased oral intake, and weakness causing falls at home. She has a BMI of 23.9. Her past medical history includes a gastric bypass done around 16 years ago, and she's lost around 200 pounds to date. She had a recent hospital course around a month ago for acute on chronic abdominal pain with nausea and vomiting. This was complicated by hepatic encephalopathy, and ultimately she was discharged on lactulose and rifaximin. On her current admission, a head CT was performed showing no acute intracranial pathologies, and an abdominal pelvis CT showed severe steatosis. Ultimately, she was admitted to the ICU for management. I've included her labs on admission for your reference, and we'll go through some of them a bit more in detail when we utilize the diagnostic algorithm. All right, our next audience participation question. For patient SH, which of the following characteristics indicate the possibility of gastric bypass-related hyperammonemia? So is it A, acute encephalopathy, B, history of gastric bypass, C, middle-aged female, D, an elevated ammonia level, or E, all of the above? Yep, so the answer is E, she met all of those criteria. So now moving on to our diagnostic algorithm. This patient presented with ammonia level of 53, so checkbox for the hyperammonemia. I've included her LFTs, so her T-belly, alk phos, AST, and ALT were relatively normal, so no signs of liver dysfunction. Her arterial pH on admission was 7.36, so she had a normal pH. Her glucose level was 85, so she was normal glycemic, so indicating that it may potentially be due to a urea cycle disorder. So I've included what her aminogram looked like. So this was when we were in Cerner, but this was drawn around 10 days after admission, and then we'll look at it a little bit closer in detail in a minute. Our next question. Which amino acid profile would be beneficial in diagnosing a potential urea cycle defect in patients with GABA? So is it A, cysteine, B, glycine, C, tryptophan, or D, citrulline? Yes, so the answer is D, citrulline. So looking back at our urea cycle, looking for citrulline, arginosuccinate, arginase, or ornithine in our amino acid profiles to identify potential deficiency in our urea cycle. So going back to our patient's aminogram, looking at the components of our urea cycle. So she did have a relatively normal arginine, arginosuccinic acid, citrulline, and ornithine level. So it potentially might not be due to urea cycle defect, as our diagnostic algorithm had pointed out. Again, emphasizing that the potential mechanism and trigger of GABA is pretty difficult to determine. I've included her micronutrient labs along with our EUH reference ranges. So in her previous admission a month ago, they did draw some micronutrient levels. Her vitamin A was low, vitamin D, ceruloplasmin, copper, selenium, and zinc. And for her current admission, very similar low levels. She had an undetectable B6, and we did draw a carnitine level, so those were relatively normal as well. In terms of the medication management, she was started on the classic combination of lactulose and rifaximin, and then I've listed the nutritional supplementation she received. So supplementing those low levels, and this was outside of parenteral nutrition prior to when she got started on it. So that brings us to our nutrition management. She was first started on a soft and bite-sized diet when she first came in. However, as I discussed before, this is typically not preferred as we can't tailor our nutrition as well with our protein and amino acids. It wasn't until day 5 of her admission that she was started on CPN. And so I've included the protein adjustments that were made inside of the bag. So on day 1, we started with around 0.8 grams per kilo, which is relatively lower than we would typically start in a normal patient. And on day 3, you can see that we upped the protein up to 1.5 grams per kilo, which is typically what we would aim for in a patient in the ICU. And then from days 5 through 9, we slowly tapered down on the protein. And so looking at her overall patient hospital course in correlation to her protein management, on day 1, when she was admitted to the ICU, she had a relatively high level of ammonia, 53. And so on day 5, when she was transferred to the floor, that's when PN was initiated and also palliative care was involved. So after around 5 days, she had an unchecked ammonia level and it spiked back up to 150. So kind of potentially with that increase in protein and parenteral nutrition, the team had added Juven, could have led to that increase in ammonia. And then on day 18, she was discharged. So you can see her ammonia level start to drop back down. We had back down on the protein and the parenteral nutrition. And so she was one of our success stories. She was debilitated post-hospital stay, so home health was involved, and she was discharged on vitamins and rifaximin. So going back to those other patient cases that I had mentioned previously, patient 2 also had very similar low micronutrient levels, and same with patient 3. For assessment, using that diagnostic algorithm again. So with patient 2, they presented acidotic. So their hyperammonemia may have been from an organic acidemia versus a pyruvate metabolism abnormality. With patient 3, she presented very similarly to patient 1 that we just discussed. So she had a normal pH, a normal glucose, indicating a potential urea cycle defect. She did have a normal citrulline level, and then again, it kind of stops there in our diagnostic algorithm as we didn't have an orotic acid level. In terms of our management, very similar, consulting our team, treating those vitamin deficiencies and adding on rifaximin, with patient 2 receiving CRT. In terms of the outcome, patient 2 reached an ammonia level of 280. She had multiple infections and quickly developed multi-organ failure and passed. Patient 3 reached an ammonia level of 160, and she also was ultimately transitioned to hospice and comfort care. So these 2 patients kind of reflect the other half of that 50% fatality rate in comparison to our first case. So since those 3 cases that I've presented, there have been multiple cases just this week, consulted on 2 of them. So with this high mortality and lack of information, Dr. Prem Kandaya initiated the process to create a GABA protocol. So we would want to initiate this protocol in patients with an ammonia level greater than 100. We would want to monitor those plasma ammonia levels every 8 hours. We would want to stop any high protein enteral feeding, stopping that juven, as I had mentioned before. We would want to draw tier 1 and tier 2 micronutrient levels listed here. And again, those tiers are based on the common deficiencies that we've seen among our patients that we've treated and in gastric bypass. Step 3 would be to start empiric tier 1 micronutrient replacement therapy after drawing levels. So if we're consulted, we typically put those in our parental nutrition, or it's added as outside supplementation. For copper, selenium, B3, vitamin A, D, and E, we would want to wait for the level to come back and then replete it if it's low. For our macronutrient replacement, starting D20 if they have a central line with lipids, and then when it's possible and safe, adding trophic feeds with a pre-dialysis enteral formula, as those typically have a lower amount of protein. Step 6 would be our controlled hyperammonemia phase. So once their ammonia level is less than 80, our team will typically titrate the protein in parental nutrition, similarly as we did in patient case 1, of course taking into account if they are on CRT. So our key takeaways from this presentation is that diagnosis is difficult. So knowing those main indications and symptoms of how these patients typically present, if they have that high ammonia level and history of gastric bypass, then kind of looking towards the GABA direction. There are patient cases and references available and our pending protocol, of course. Remembering to draw the appropriate labs early as they do take time to come back. And then knowing your treatment options and of course consulting our team is always recommended. I'd like to thank Vivian, Dan, and Nisha for their help in this presentation. And I will now take any questions. Thank you. Yes, Dan?
Should we try to avoid the steroids?
So we had a question in the audience if we should avoid the steroids if possible. I think it would depend on the patient and their situation, whether or not we would want to avoid steroids, but I might have to get back to you on that one. Mm-hmm. In the ICU, yeah. Yeah. Yes.
Comment on the protocol. I just coordinated the smart people like Griffith and Dave and Vivian Zhao.
Yes.
Put it together. And lots of teams doing stuff. So I would take a lot of credit for these people on this.
Oh no, you initiated it.
Yeah. The essential hydroxyl acid. You know, when they in the 2017 trial, like the fine why
Yeah.
why flat is determination and how long, how many patients, and what the side effects were. Did you come across anything else?
I only came across that they completed in 4 patients and then it was stopped because of the high toxicities that I mentioned. So like the bone marrow suppression, hepatotoxicity.
How long they ran it for?
Not that I saw. It was very vague in the clinical trial. Yeah.
That was mostly in kids, right?
Yeah. Alrighty. Thank you guys.